Thank you for inviting me to this symposium, Professor Lokanda. I'm going to talk about the foraminal bone resection. I don't want to call it the foraminal or foraminatomy because these kind of things sometimes confusing the surgeons. It's the bone resection with the foraminal access. Before starting that, as you said, I'm working in Istanbul in the Florence Nightingale Hospital there, and this is my disclosure. As you mentioned, I'm responsible for the international and the trainings of the RiboSpine company. As we know, we have two different approaches, the foraminal and the interlaminar approach, because here I would like to underline it. I don't want to call it a transforaminal approach because trans, every time we don't pass through the foramen, yeah? That's why I call it the foraminal approach. And as you know, we have different foraminal approaches like transforaminal, intraforaminal, or extraforaminal approaches. And apart from that, according to your entry point, we have different approaches. The terminology for the posterolateral approach. Usually, we measure the midline, and then 10, we find a midline and measure 8 or 10 or 12 centimeter to the lateral on the disc level. Then we find the entry point. With this entry point, our working angle is about 45 degree, and this is a really good approach to reach the intradiscal space. But the problem, as you can imagine, the ventral epidural space. We cannot reach the ventral epidural space without doing a bone resection with this one. And the solution for that is to do bone resection. This is one solution, and the other solution also you can choose more lateral entry. And why this way you don't need to resect bone or less than the post-lateral approach. These are the techniques to enter. Um, what is the terminology of extraforaminal approach? Basically, it means that we are working outside of the foramen. If you want to do the bone resection in the foramen, then you need to stay outside. Or if you want to resect or decompress the existing nerves due to the herniation, we need to work outside of the foramen. For the discectomy, yeah, divide it for stenosis and the discectomy for the bone drilling. For the discectomy, in our philosophy, we believe that, of course, the foraminal approach is the least invasive approach. It's an open gate to the spine. We would like to do the operation with the foraminal approach, but according to our philosophy, we have some restrictions to do that. This is only maybe when you attend these kind of symposiums or when you check the literature, you can see different tactics here. All of them are done really successfully, but we can only share our experience with you right now. What we do usually, if we see that the iliac crest is higher than the foramen, we prefer to do interlaminar approach. But of course, the other solution here, like a L5S1 level, you can come a little bit oblique, and you can drill the bone and the facet joint, and then you can access to the spinal canal. This can be a technique with the bone drilling, but for me, it's much easier to do interlaminar approach instead of doing a foraminal bone drilling. Also, as part of the 4-5 level, again, you need to care about the iliac crest. The second criteria for me is the migration of the herniation. If it is located in the red zones, like upper than the upper pedicle, lower edge of the upper pedicle, or upper edge of the lower pedicle down to, we prefer to do interlaminar approach. As you know, we are restricted in the cranial side with the exiting nerve, and also we are restricted with the pedicle in the caudal side. But of course, it's not. You can do like this. You can do bone drilling with the pedicle or with the facet joint, and you can reach more cranial caudally here. But we don't prefer to do more one. And the third criteria for us is the foraminal size. If the foraminal size is narrow due to the hypertrophy of the facet joint or the short pedicles, then it's not easy to pass through the foramen with the instruments and do the discectomy inside the spinal canal. And then the other option here again We prefer interlaminar approach. I will come this topic later. But the other option that you can back on the junction of the pedicle or to the facet joint, and you can resect some part of the facet joint, and then you can create a better access to the spinal canal. Okay, to do foraminal bone resection, what are the options in our hand? Uh, Basically, the technique with the manual drilling is known as a foraminatomy system. Basically, it is with the manual drilling system under the fluoroscopy, step dilators, and the steps drilling. Step by step, you can enlarge the caudal side of the foramen, and at the end, you can introduce your vertical cannula and then the scope and start the operation. It means that the operation divided two parts. One first part is with the manual drilling under the fluoroscopy. It is kind of blind approach. And the second part, then you do the operation with your endoscope. And the other option for us is to do extraforaminal approach with the shaver system. Especially we work with the deflectable shavers that we don't change the direction of the instruments a lot during the operation. As you know, the exiting nerve root and the ganglion that you can patch and you can squeeze it with the pedicle. If you change the direction of the system a lot during the foraminal approach, basically we prefer to do with the angled instrument. These are two things. What we do, there's different techniques. Of course, you can back on the bone. We can start with the front cutting burrs. But basically, if you want to do enlarge the foramen to create a better access to the spinal canal, then we do like this. We place the needle at the dorsal and on the medial pedicle line, and then we introduce the guide wire. Guide wire of the system is a little bit stiff than the regular system. And then over the guide wire, we go step by step with the dilator and the working sleeve. We start with the smaller one and then we switch to the bigger one. Then we drill with the step by step from smaller to bigger. Then we do like this under the fluoroscopy with the drill. We can resect that part. Be careful here with the manual drilling system. You can work only at the caudal side of the foramen just to create a better access to the spinal canal. It doesn't mean that you can decompress the exiting nerve root in the cranial side of the foramen because it's really, really dangerous under the fluoroscopy, blindly working in the cranial side of the foramen. Then the option, if you want to do decompression to the exiting nerve root, like a ACP impeachment to exiting nerve root, then we definitely have to choose burr system, shaver system, especially we prefer to choose an angled one so that we can drill the caudal cranial side of it. Usually we prefer extraforaminal approach in these kind of cases. Then we place our needle and the system at the caudal side, junction of pedicle to the ACP. Then we dissect all the tissues and then we start the operation like that. And under our visual control, we do the bone drilling and you can protect the exiting nerve root. You see the video demonstration with the deflectable shaver systems. When you press this button, the tip is deflected. You see the pedicle here, the standing facet, and at the same time with the cannula, we protect the exiting nerve root, and we do everything under our visual control, and you see you can expand your resection over the exiting nerve root. Now we are at the left side of the patient. Now we dissect or we prepare the foramen. At 3 o'clock you see the pedicle, 12 o'clock you see the ACP, and at 6 o'clock you see the disc space. And we put with our cannula, we protect our exiting nerve root, and under our visual control, you can resect the bone like this. Now you see the video from the straight burr, and also we can use, as I said, the diamond dissectable burr, and then once you run resect the facet part of the SAP, then you can reach to the spinal canal more better, and then you can do discectomy, and also you can reach more medial. But this doesn't mean that you can decompress the recess sufficiently in this technique. This is just for discectomy from my point. Why we don't prefer lateral foraminal approach to decompress the recess? Because there's a high risk that to do efficient decompression on the recess, you have to resect the major portion of the facet joint, and there's a high risk that you can damage the facet joint, and still, even you reach that part, still you might have compression on the nerve structures from posteriorly, especially from and the recess from the ligamental flavum or the upper part of the cranial lamina. Then, in case of the compression of the recess, we choose interlaminar approach. Again, as a summary, for the central stenosis in our philosophy, we prefer interlaminar approach. Definitely, you need to go to the contralateral side because, and if there is a lateral stenosis on the recess, we prefer interlaminar, not the foraminal. But if there is a foraminal stenosis compressing the exiting nerve root, then we prefer extraforaminal approach with the shaver system. But as I said, for discectomy, you can use your manual burr system to just to do the bone resection on the caudal side of the foramen. Thank you for your attention from my side.